Thank you, Ben and Ajita, for the invitation. Thanks, guys, for sticking out till the end of the session here. I'll try to get us a little ahead here if I can. These are my disclosures. I work for Industry Sum, none of which have any bearing on this talk. I'm also the treasurer for the HSQC, but they don't pay me, so that doesn't count, right? So real quick, I wish I had Jonah's fancy in-app monitor. I got to learn how to do that. But just by show of hands, 35-year-old male with an 8-centimeter ventral hernia who's obese and diabetic. Who wants to fix him laparoscopically, intraperitoneal? A lap IPOM. Anybody? Robotic IPOM? Nobody fixes hernias here. Robotic IPOM? Who's going to do an open ventral hernia repair? Mesh? Okay. Wow, it's a quiet crowd. Okay, well, we're going to go ahead. So the point is, how do you decide? How do you decide which way you're going to do this hernia repair? And then how do you monitor and potentially improve your outcomes? I think there's a lot of ways that we learn technique. There's a lot of ways that we learn quality and outcome measures. One is meetings. You come to a meeting like this, you hear a group of at least self-proclaimed experts telling you how to do hernias. You can go on social media and find a lot of people to give you some good advice. These are all valuable things, but at times, and I'm guilty of this too, it can feel a little bit like show and tell, like, here, look what I can do. Do we really know how all these patients are doing in the long run? Not always. So it's something just to keep in mind. How about evidence-based medicine? We're all, at least pay good lip service to this, but the literature on hernia repair is not that great. Most of the data that we rely on to make these decisions is level 3, 4, or level 5 data. I actually did a quick PubMed search for ventral hernia repair, returned just over 4,000 results. When I added randomized control trial to that, it dropped to 64. And as I reviewed those, only 30 of them were actually randomized control trials. We don't have a lot of high-level data on hernia repair, and most of it really can't account for the variability that we see in technique, mesh selection, fixation, as well as the surgeon experience and the patient factors that go into this. How about big data? It's very compelling when you're looking for small changes over numerous variables. You really need a lot of information to be able to detect the difference. So you have some pretty large databases, both administrative, nurse abstracted, surgeon entered databases that can help get to the bottom of some of these questions. I'll use NSQIP as an example. Really at the heart of it, it's designed to be a quality improvement for your local hospital and reduce complications. I'll use just a couple of studies as a quick example of what NSQIP can do. This is a study by John Fisher, taking a huge number of patients, looking at risk factors that go into wound complication events, grading those according to their odds ratios for wound occurrence, and then developing a grading scale that was internally validated. This is a pretty useful tool. This is now something that we can use to give our patients an idea what their wound risk might be, or maybe use this to modify some of those risk factors up front. Another study recently published, laparoscopic emergency hernia repair, pretty underutilized, but the outcomes seem to be pretty good. And looking at this paper of over 13,000 patients, the authors sort of conclude, maybe laparoscopy should be used more often. But what's missing in this data, in particular this second study, is a lot of hernia-specific things that really matter to the hernia surgeon. How big was that emergency hernia? Was it a 1-centimeter umbilical hernia, or was it a 10-centimeter recurrent incisional hernia? What's the volume and experience of the surgeon? Was this a conversion from lap to open? Was there a bowel injury? What kind of mesh did they use, or did they use it at all? And then what kind of long-term follow-up is there? So it has its place. It has a very important role, but it doesn't answer everything that we need. So really what we want is to have a high level of accurate and complete data. We really want to have disease-specific data, something more than just the broad strokes that are often captured in administrative data. And we ideally want to have some patient input in this as well. We need longitudinal data, as was presented earlier. And ideally, all of this data works together in a collaborative way that the surgeons can have ongoing quality improvement and performance evaluation. It takes big data to do this, but it needs to be problem-specific and specific for the surgeon. The last way that we tend to look at data is just our own anecdote. We tend to think that we're pretty good at what we do, The problem is this graph is a better representation of our reality. We probably start off thinking we're pretty good until you're in practice long enough to start seeing your own complications, and then you fall off the cliff there into your own existential crisis of how good you are. So I think this is where something like the HSQC or like some of the things that were mentioned previously can have a real impact. Just to show you that the HSQC is a quality collaborative based out of the Hernia Society. It's been in existence now since 2013. There are over 47,000 patients in this database, in this registry now. And here's an example of some of the work that's been done out of this. We've looked at use of robotics for ventral hernia repair in a couple of different studies. Does smoking really matter, and does smoking cessation really matter? We don't know based on HSQC data. Do drains make a difference? Do they increase infection rate like some of the guys in our M&M say constantly? What about post-operative analgesia? Is tap block better? Is epidural better? These are some questions that we hope to answer. But I think more than what a couple of guys who nerd out on writing papers do is we want to know what this can do for your average general surgeon. This is the new tagline, by the way. We're putting this on the Twitter account or something. I don't know. I don't tweet. I'll leave that to Taylor. It lets you track your patients. So this is our data at the Greenville Health System that I pulled yesterday. Blue bar is us, HSQC, and the green as a whole. So you can see our practice. We tend to do a lot of complex patients. We do more recurrent hernias, higher BMI, a lot more smokers, diabetics. Should I be? I'm not so sure, but it lets me track that. It lets me get some feedback on it. It lets me track that over time to see if I'm making a difference on maybe optimizing some of those patients. I get to look at my outcomes, 30-day SSI rate, 30-day SSO rate, requiring readmission or intervention. I can look at patient-reported outcomes, the ventral hernia-specific quality of life or inguinal hernia-specific quality of life that you can see here. I can look for recurrence. The long-term data is starting to emerge now from the HSQC, and that's what we're looking forward to in the years to come. So 1-year hernia recurrence rate, it's probably a little higher than most of us would like to admit, but these are what the data say, and it gives me a chance to really start to look into that. And then as Mickey already mentioned, you're starting to track opioid use is obviously a hot topic and something that we've worked very hard on in our system to reduce, and we've been very successful in doing that. And this is just one more tool to allow us to track our own outcomes. It lets us to assess risk. I'm sure you're probably familiar with the ACS NSQIP risk calculator. This is one based on, again, that large volume of patients contained in the Hernia Society that lets you not only plug in patient factors, but some very specific hernia-related questions like what type of myofascial release are you going to use to give you a better predictive score of what their SSI or SSO rate might be post-operatively. And I think one of the most important things is that it gives us sort of a collective power. We all as surgeons feel like we need to be the ones to define quality. We don't like it that our politicians or our government or healthcare or payers or our hospital administrators are the ones defining quality. We know best what we do and what our patients expect, and I think that should have a big role in going forward. And if we can use this kind of data to define that quality, then it puts us more in the driver's seat. It also gives us a seat at the table with some of those key players, with the FDA, with CMS, post-market analysis empowers us as surgeons to have a seat at the table with the payers, with our hospital administration. But all of that requires information, and this is at least one great source of that information. Just some of the things that we've done at our institution, largely based on Ajita's paper looking at epidural use, we looked back at our own and found that we probably had a higher length of stay using epidural, started transitioning to tap blocks, and just published data on that showing a significant reduction in length of stay and opioid use actually when we transitioned to tap block away from epidurals. It's allowing us to track opioids and hopefully even further reduce our prescribing. We've made a significant impact already, and I think we can do even more. We can do trials. We're hopefully going to start an embedded randomized control trial using the QC as the basic platform looking at antibiotic irrigation. And then, one thing that came out of our quality summit that I'll mention in a minute last year was VTE reduction. We're one of the higher outliers for VTEs in the HSQC. And looking at the better performers and finding out what they do and what their practice is, hopefully will help us to improve on that outcome measure. It's not perfect. There's things that we still need to do to get better. We could make it more user-friendly. We could have, a patient engagement app. We're not that sophisticated quite yet. We still have used this a bit more as a repository for data and research more than we've used it for true local quality improvement. But it doesn't mean we can't get there. And as we build the data, we're able to do more and more of that. So hopefully this is going to be something that gets more and more personal for the individual surgeon to be able to get real-time feedback from this quality improvement data set to truly impact the care of your patient. One of the highlights, I think, of last year is the first HSQC Quality Improvement Summit. This is kind of the first meeting of its kind using this registry data to start looking at some of these questions that we often ask in hernia repair and inviting some of the key players in each of these areas, looking at high performers in robotic, in lap, and open hernia repair, and having them come and share their experiences. So we had a lot of expert technique talks. We looked at the impact of pre-hospital chlorhexidine scrubs, and basically it doesn't work and might even make your risk of infection higher. Can we prevent VTE? Things like this are really, really impactful tools that we can use to arm the surgeon to go back and make a quality improvement in their patients. And I'm looking forward to our next meeting coming up in December, where we're going to focus a lot on optimizing care for umbilical hernia patients. We've all seen those patients in our office that have a disaster abdominal wall. It started with some just little umbilical hernia. So I think this has the potential to be really impactful by using this big data in a meaningful way. Continuous quality improvement is really key. It has to be more than just data that lets us publish papers. It has to be more than just a randomized control trial. It needs to be all of those things together. It needs to be surgeon and patient-led. We need that voice. We need that seat at the table to have our voice heard and define quality. It needs big data to answer some of these big questions, but at the end of the day, it really has to be local. We need the big data to answer the questions so that we can feed it back to the local surgeon who knows their own practice, their own community, their patient expectations, their own training, their own expertise, and their own quality outcome measures. And that's ultimately what we hope to do with some of these quality registries. And I think what each of the other speakers has alluded to, and each of us have found slightly different solutions too. There's probably some way that we can all collaborate together and meld these into systems that will really benefit our patients. That's all, and thank you very much. Look forward to questions.